My pleasure to, well, he doesn't really need an introduction. Next speaker, Phil Allen, professor of psychology at the University of Akron, dedicated his life to Chiari and really a pioneer. And he's going to talk about effect of pain, catastrophizing, and the relationship between pain and disability in Chiari. Thank you, Phil.
I might add that what we're doing today sounds like a good start in addressing some of the issues with how entities interact. So if we had better communication, maybe between all of the constituent groups, the patients, the surgeons and the researchers, maybe we could address some of those issues. Yeah. So that, okay. Today, there are a group of us here, including two of them sitting here, who are also part of this project. It came out in the Journal of Health Psychology earlier this year. And we're looking at several factors: pain, disability, potentially depression, and pain catastrophizing. So let's talk about these a little bit. First, I would like to acknowledge funding from Conquer Chiari. So let's define some of these things. Maybe not everyone would agree with these definitions, but they're a start. So let's define pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual and potential tissue damage. Let's define disability as functional impairment, such as driving. Pain catastrophizing is an exaggerated negative orientation toward actual or anticipated pain experiences. And much past research has shown that pain catastrophizing actually has an effect on how pain is experienced. Now, until this particular study, it had not been applied to Chiari malformation, though. And then depression, and I might add here, we're not talking, mainly not talking about major depression, which is a very serious thing where people may be out of contact with reality. This is on a continuum, and we're looking at gradations of this mood effects that include sadness and frequently anxiety. Now, why are we doing this? So we do know that pain is correlated with disability. And we also are finding out more and more over time that pain is exceptionally difficult to deal with. So is there some way that we can have an effect on the relationship between pain and disability, even if we can't completely get rid of pain? Now, the reason that it's important to study this, and I'm pretty sure most of you in here realize this very well, we can't completely get rid of pain. In fact, frequently, we're not very good at dealing with pain at all. And since we know that overall, if you look at it, that there's a fairly linear relationship between pain and disability, this seems like a hopeless cause, doesn't it? That we're going to have a high level of disability because we can't get rid of the pain. I think this study suggests that is not necessarily the case and gives maybe a glimmer of hope to a lot of issues that have been very difficult to deal with chronic pain and Chiari malformation. So we have done a couple of studies, I believe the only studies, on acceptance and commitment therapy, which is a intervention that is known to work as well as about anything with chronic pain and Chiari. And what we have found, unfortunately, is that, in fact, we can't get rid of the pain, but we can help people cope better with the pain. So, what is going on and how that is possible? And that's what I think the rest of what we're going to talk about will deal with. So, we have pain, and it depends on how long, for example, and I think we need to talk a little bit first about types of pain. But let's summarize here. It appears the act does not reduce the actual experience of pain. It helps you cope with that pain while not reducing it. One factor that might link these two issues is selective attention. Now, selective attention is involved with many things we do in life. In fact, attention is the glue of consciousness. It's the glue that binds functional things together in cognition. In this case, we can focus on things, and the other side of the coin is filtering things. We have focusing and filtering. And we can inhibit things by filtering them. So maybe selective focused attention might allow individuals with Chiari malformation to inhibit this negative orientation to pain. And if they do that, it may actually lessen disability. Now, I should mention that how we define these things. In terms of pain, we used the short form of the McGill Pain Questionnaire. And for disability, we used the NDI, the Neck Disability Index, which is the Head and Neck Disability Index. Probably more stuff involved with the head, although some people vehemently disagree with me on that, and Chiari, that it may be the neck as well. And we collected a number of measures in this study and it was a web-based study that looked at 372 adult patients diagnosed with Chiari malformation. And by the way, about 2/3 of them have been decompressed and 1/3 had not. And it turned out that in terms of these analyses that we're going to talk about, it didn't matter on surgical stats. Although I will tell you something that I think is good news for decompression surgery. Decompressed patients show less severe symptoms in terms of anxiety and depression and so forth than non-decompressed patients. So if you want probably the best evidence for the efficacy of decompression surgery, maybe it is looking at that people that supposedly have less severe symptoms actually show worse anxiety and depression and stress and almost like trauma-like symptoms than people that have been decompressed. Okay, we have these two types of pain. We have chronic pain and acute pain. I'm not sure many people really would want to get decompressed just with a Valsalva headache, maybe. When it gets to be more chronic, that becomes more of an issue. And some of our group have argued for many years that probably what is going on when you have chronic Chiari headaches is that the brain decides that it's in pain. And when the brain decides it's in pain, we call that centrally sensitized pain. and you no longer need a pain signal to say you're in pain. So this isn't nociceptive pain or sensory pain. The brain decides it's in pain, and I think that's a lot of what we're talking about here. And this is very difficult to get rid of or attenuate centrally sensitized pain. So maybe what we can do is learn how to reappraise that pain in a way that is easier to manage. Okay, this is some description of what our 372 patients look like. We have a pretty high level of disability here, as you can see in the yellow highlighted stuff from the Neck Disability Index. And we have different types of pain here from the McGill pain scale. Total pain, continuous pain, and affective pain are the ones that showed up highest here. And once you get around 5, you have problems because that's chronic pain. And you have to deal with that in a way, because once you get to around 5 on there, you start seeing risk for self-harmful behaviors and stuff. Affective pain, though, is not neuropathic pain, and yet it appears to be what we think of as chronic pain in Chiari. We have done a pretty large study with factor analysis and have shown that affective pain and Chiari and the McGill total pain are the key factors for studying pain. Now, we also have 3 subscales to pain catastrophizing: rumination, magnification, and helplessness. And we want to keep that in mind. It turns out that 2 of those 3 matter. So we have found that, in fact, our ability to carry out a memory study, for example, is related to selective attention ability, self-focused attention. People with higher individual differences in self-focused attention were able to manage moderate levels of pain better than people that had lower levels of self-focused attention. Looks good so far, right? And we have found overall that there is evidence of pain occurring in different ways that refer to what we might call allostatic load. So if we can minimize allostatic load, then we might decrease disability. Now, allostatic load is going to go up when we can't manage that pain. And that is particularly the case when we catastrophize pain. Now we can speed up. We already talked about that. And this pain catastrophizing scale allows us to look at these 3 characteristics of pain catastrophizing. Now, that is a mess. Look at the yellow highlighted ones. All we're showing there is that, in fact, pain catastrophizing and pain and disability are all intercorrelated. And that lets us do the statistical part. So what we used is the process model, where we can do mediation. And some people say mediation is causality. No, it's not causality. It's an explanation of the relationship between pain and disability. Well, what we found out is that overall, that pain catastrophizing does mediate the relationship between pain and disability. And that is with the total pain catastrophizing. We can also, and we won't get into the statistics here, it also showed mediation by 2 different subscales, but not the third. And finally, depression did not mediate that relationship. This is not depression. So what does that mean? These results suggest that reducing pain catastrophizing in Chiari malformation individuals may reduce disability levels even if pain levels are higher. And that almost sounds too good to be true. So that's the main outcome of this study, that it does look like even if we can't reduce pain, we can reduce its effect on disability.